It is now my pleasure to introduce our speaker today, Trish Tulloch. Trish, I'll hand it over to you.
Oh, thank you and welcome, everyone. It's great to see all of you again today. I know I just want to remind you that this webinar series, including today, is being recorded and archived. So the coalition, those of you who are members of the Healthcare Coalitions for Region 3, you will have access to all the archived taped webinars and the information. Now, as Leisha said, in that lower right-hand corner, there's the files, and I'm hoping that you've had a chance to download at least the tools for webinar 2 today, because we'll be going through them or just referencing them today. And appreciate that. Now, I'll be watching your questions, but what I want to do really is begin with the questions from webinar 1. I try and answer the questions during the webinar or at the end of the webinar. Sometimes I don't receive them until after we've closed down. So at the beginning of each webinar, then I'll review the questions from the previous webinar, because it's helpful to all of us to have that information. And I do appreciate those of you who emailed me directly. Excuse me, on the initial slide, you can email me directly, Tricia, and that is rbc@netstep.net. So during and after the first webinar, we had a few of these questions that you can see on this slide. Is it necessary for an outpatient facility that closes prior to disasters to update their EPP annually? And some of you are really clear. We reschedule our patients, and of course, staff don't report, and then we notify patients and staff when we're reopening. And we already work with local fire and rescue providers. Our patients are totally responsible for their own arrangements. What EPP regulations apply to us? So this is really a reminder, because I did have a few questions on this the last time. So this final rule applies to 17 healthcare providers, and you can see on the right-hand side that this outpatient webinar series is really for a very diverse group. So one of the qualifiers for you to determine if you have to comply with the final rule is that you are a Medicare or Medicaid participating provider. And in that case, if you are, and you're listed on this slide, then you are required to follow the EP rule. So the question that came in, as many of you know, they want you to prepare for unexpected, not just natural disasters, but unexpected emergencies and disasters, such as a bomb threat, or cybersecurity, or an active shooter, or a chemical spill. So even though you are well prepared, I know that you are, and our industry as a whole is very, very well prepared for predictable or forecasted natural disasters such as hurricanes, ice storms, snowstorms, and everything else, flooding, many of us are not as prepared for the unexpected disasters. But the qualifier for the two of you that asked then is you need to be a Medicare or Medicaid participating provider to be qualify under that final rule. So that's the response to that one question. Now, all of us have to follow core requirements. So in webinar 1, we all know that we have to do a hazard vulnerability assessment and analysis, an HVA. You're getting ready probably to do that again this year, and then update your EP plan based on that updated or annual HVA. They really want you to look for gaps. What are weaknesses? Now, many of you or all of you were involved with hurricane season and disasters, closely last year. What can we do to prepare and be better prepared this year for hurricane season? We learned many of the best practices and updated lessons from last year's hurricane season, so we're appreciative of that. So if you lose power, what's your backup if you're required to have a second generator source, or if your office was destroyed and you couldn't provide service during or after the hurricane, then what happened? And so many of your colleagues in those southern counties, both coastal and inland, really were affected by Hurricane Irma. And how do you protect your clinical records, your electronic medical records, and your communication plan? So the answer, of course, for webinar when questions is you all have core requirements that you're required to follow, and then some of you have additional requirements depending on what type of certified provider that you are. So I gave a couple of examples in these next few slides. So if you are, for example, a rehab clinic and you're under the conditions listed here, the 485 conditions, then they expect you to have emergency plans updated annually and collaborate locally with your fire and safety and appropriate experts. You'll have to have the documentation when you have your surveyors come in, your state surveyors come in. And if you're a dialysis center, and we learned many lessons in the last year's hurricane season with the dialysis centers. Thank you to those of you who helped staff some of those shelters because of the need for staffing. And of course, some of the dialysis providers actually went in the shelters and provided the required dialysis to the evacuees who were in some of our special needs shelters. So we're grateful for those of you who volunteered or participated in those initiatives last year. Now, the dialysis facilities then under the final rule, the 494 conditions, are really required to contact their local emergency preparedness management, contact folks at least annually to update them on your dialysis needs during the event of an emergency, and to actually document those contacts, and then, of course, share your patient population and your facility needs before an event occurs. So many, if not most of you, have already done that. If you're an ambulatory surgical center, and I know that there's one on one of the coalitions that's participating in this series, then you really need to have policies, procedures, and a plan for safe evacuation from your facility. And that policy would need to include transportation, for example, and an alternate site or an evacuation location, and the surveyors would be looking for copies of agreements with other facilities. In some cases, if you have to close your facility, you may have backup agreements with other centers for staffing and to move patients as needed. And of course, then I listed PACE and dialysis down below. What do they need separately? So even though we all have core requirements, if we're a Medicare or Medicaid participating provider under the final rule, then each of you have separate. And as I recommended before, it's really important for you to go to the final rule and then look at the conditions specific to you as an outpatient provider. What specifically do you need to do? So, for example, our hospices, they're required to have a policy on how they designate healthcare professionals. How will they incorporate them into their emergency planning? So state and federal designated health professional, how will they include them? And the surveyors will look for those policies and procedures, so they're very specific to each provider. Now, in that first webinar, of course, one of you asked about the ambulatory surgical center, and that was the error on that CMS guide that wasn't updated, but a community-based drill is required for you, and that's why I listed or incorporated these slides again, just to make sure that we got that out to everybody. These are actually good guides, but again, you want to look at the final rules so you know all the special considerations for you individually. So, for example, our federally qualified health centers, they're to participate both in a full-scale community event and then an exercise of choice. Or our renal dialysis facilities, they're required to track their patients and their staff during and after an event. And you actually did that very well last year during hurricane season when they did those updates. So the core requirements then for all healthcare providers, including outpatient providers, is that you perform an annual HVA and annually update your emergency plan and policies and procedures. And of course, you can look at the interpretive guidelines, that's Appendix Z, to see what's specific to you and your type of provider. Now, when you update your plans and policies and procedures and plan, you might want to look at training and testing differently. So this year, you might be training and testing for something different. You identified a gap, or maybe you identified another risk that you hadn't last year in your HVA. So our goals today really are to look at specific planning, emergency operations planning, EOP, and some management requirements that you want to consider in your EOP and your specific policies and procedures. And then finally, consider resources and asset planning during and after an emergency, and you'd be detailing those in your plan as well. Now, for the policies and procedures, of course, there are a number of websites, that you can access templates for policies and procedures. So, and then, of course, your coalition, your state, FEMA.gov, and ASPR Tracy are a few where you can access templates, and then you can take those and actually revise them to meet you as a specific provider. I gave you a couple of samples that we'll look at during this webinar, so that's why I recommended you download those tools. But you can take those and revise them and fit them for what works for you. So 4 provisions for all healthcare providers, and we're focusing again on policies and procedures. Now, we'll be doing the communication plan 3 weeks from today, which is May 31st, and then we'll be doing that training and testing, those updates on best practices and some other recommendations. That will be on June 7th. So CMS did a great job in detailing what their expectations are. And for the policies and procedures then, they're asking you to be specific to detail every high risk in your HVA and policy and procedure and really customize it to your agency, your special population that you care for, and your location in your region. And to start with, of course, look at your HVA, update that, and see what's new and different. I will give you an example. I see people doing their annual HVA, and depending on the type of provider and your location, people are looking at the opioid crisis. So we have some community mental health centers who are outpatient providers, and they're looking at the higher risk of overdose of family members or patients, even visitors who are entering their center as becoming an emergency, and really looking at policies and procedures based on that because of their location and the population they serve. Now, that may be applicable to you, and it might not be applicable to you. So our roles then in the new regulation is to ensure safety and well-being of staff, of all of you, of course, and our patients, maintaining continuity of care in our business operations, wise use of our resources, but primarily, as you know, supporting each other, our coalition partners and community partners and first responders, and providing legal protection for ourselves as providers. So what's the purpose of a COOP plan, of course? And that's to keep your business operational, provide essential services during a crisis. Many of you have done that during your hurricane season when you've had to relocate some patients into special needs shelters, for example, and we've actually had to cohort and staff those shelters, and we appreciate those of you who volunteered to staff other shelters last year during Hurricane Irma and after Hurricane Irma, because staffing was an issue for us and the call went out. So many of you supported those efforts. And of course, you want to continue that business. So many times, you know, the dialysis centers stepped up and provided dialysis to evacuees in those shelters as well. Business as usual to ensure that we can rapidly respond to an emergency, expected or unexpected, and then continue operations and work together as a resilient community to provide the care and services required by our patient population and our community. So, of course, your readiness, your resilience and preparedness is absolutely critical. And your policies and procedures will be able to be a guide, really, a resource and a guide for leadership and for staff for every event or threat that you've identified in your HVA. Who and when and how do we activate that emergency response? What do we do and do differently to maintain operations and provide care? And how do we reconstitute our business operations if we've had structural damage, or we've closed or evacuated, or we've had some flooding or other unexpected issues? How do we continue to reconstitute and provide care and services? Those are always the questions. So first, in our emergency operations plan, or EOP, we need to identify our essential functions. So some of us clearly have to triage patients. So if we're home care, hospice, or PACE provider, we're deploying staff into our community. And prior to an emergency or during an emergency, we classify our patients and we triage them. Who do we have to evacuate? Who do we have to move? What do we have to do differently because of staffing? Many of us know during an emergency, staffing becomes critical because many of our staff have to take care of their own family members. So staffing shortages become commonplace for all of us. So identifying essential functions, communication, and our link to community resources, our coalition partners, emergency management, and first responders is critical. So your emergency operation plans will detail each of these items, and it really documents an action plan and guide. Then your policies and procedures will drill down on each event very specifically, and that provides the foundation for decision making for leadership and staff. Now, you all know that you're required to have an emergency resource list. And I know that I'm preaching to the choir here because all of you have been well prepared working in your coalition and with your partners in your region. So every healthcare provider is required to have an updated emergency resource list with the name of people in your emergency management system and a primary and secondary contact number. So that would be local, regional, state, and then federal. And then you want to be contacting them on a regular basis and documenting that contact. I mentioned in webinar 1, where I have found many local emergency management folks and even FEMA folks who have been surprised at the complexity, the clinical complexity of the patients that outpatient healthcare providers care for. And many of you care for a very, very complex population. And we'll be updating them, as a dialysis center or as a PACE or home health, and we'll tell them how many classification 1, people who are severely functionally impaired, how many ventilator patients do we have, how many IV and high-tech patients, how many bed-bound, chair-bound patients do we have, or classification number 1s, for example. And they're often surprised at how clinically complex our elderly are, and our chronically ill patients who are in the home that you're providing care for. So that emergency resource list is critical, and it's vital that you have a process detailed in your EOP on who's going to make those contacts and who's going to document that contact and those updated contacts. Your EOP also provides lines of authority, that incident command, who actually pulls or activates your emergency plan. It will list alternate sites, so if your office is closed, it's in an evacuation zone, or it's been flooded, or you've had structural damage, where will your office pick up operations? So it'll list alternate sites of operations. And also, if you're required to have memorandums of understanding for evacuation or transportation, that you'll have contracts in place for that. So your EOP will be clear about lines of authority, alternate sites and communication, and then the backup systems. And you always want a backup for a backup. Don't you know that? And we have found that often when we are required to shelter in, and some of our outpatient providers, for example, PACE, or our community mental health centers, we're required to shelter in, or our hospice houses or facilities are required to shelter in, and that we actually have to have power and food and water for that 7-day time frame. So it's just important for you to know that in your EOP, you're going to have a backup and a backup and a backup, including if you lose, of course, power. So communication is a requirement for all of us, and having that reviewed and updated annually, I find that's our biggest gaps for outpatient providers, that our call-down lists aren't updated, our phone lists. I know that in many of our rural areas, we often have trouble reaching staff when we have an emergency, and I've had problems, as you have, during disasters where staff are out in the field and they can't reach the office at all because we've lost power or cell coverage. So you want to identify communication gaps and look at other multimodal communications to do that. We'll talk more about that in a few weeks, though. You do want to have primary and alternate means of communication internally and externally. And be clear in your EOP how you're going to be communicating with staff and patients and families and volunteers. So many of you in your EOP have already written a radio announcement. You've identified what radio station you'll be making public announcements over, and you've already written it, and you know how to initiate that if you have to make contact with staff and patients and family members because you've lost other sources of communication. So you'll be updating your resource list, making sure those contact folks are still there, by the way, and then, of course, making sure you have the documentation to show your surveyors that you contact them on a regular basis, and I would say at least quarterly, so that they understand where your facilities are, your patient population, and that you want to participate in any community exercises or drills if possible. Now, I know that many, if not most of you on the coalitions have already done that. Now, just a reminder to all of you, if you have any questions, please feel free, type them in the chat box on that lower left-hand side, and I'll try and respond to them during or at the end of this program. Now, the first tool that I gave you, if you downloaded them, the first 2 pages are a sample EOP table of contents. So this is what we would require in your emergency operations plans. And of course, the specific policies and procedures for specific events are what we want to focus on. So those are listed on page 1 and 2 for you for quick access. And then if you're a specialized provider, you may have to enter in other things, such as sheltering in, for example. And we tried to put everything in there: evacuation, transportation. Under the appendices, you would have your up-to-date emergency resource contact list, and that's where you would keep that along with your evacuation maps and other maps that are helpful for staff. So these are the key components of your EAP. Of course, your recovery plan and your special occurrence protocols, that's going to be specific to your agency. We're obviously going to go into more detail on the incident command system, and we'll be doing that in 3 weeks on May 31st. So policies and procedures then, a guide for leadership and staff. What's specific to your agency? Who activates your emergency plan? Do you have an alternate? So is it your administrator? If the administrator's gone, do you have a first alternate and a second alternate? And what is the means of communication? Internal and external. Who's communicating with your local emergency management folks and your coalition members? Who's managing safety and security and staff during the disaster? So you all have a call down with a communication list. You have that electronic, and hopefully you have that hard copy backup so that you're using that. I know of your home health, PACE, and hospice, we have that backup in the office, and our leadership who are on call 24/7, we have that backup up with us all the time, 7 days a week. And then who's managing your resources and assets? And that's often an issue, of course. Usually our financial folks are tracking the care and services provided during and after a disaster. We're cohorting patients in an evacuation center, and we may or may not have our electronic record, so we're keeping track manually to submit that, both for reimbursement and to assess our response and gaps during and after. And our resources, how did we manage to get the supplies that we needed to provide care during and after? So our management requirements then, you'll have to look carefully during each of these, what's required for you as an outpatient provider. So some of you are required to be able to locate staff, to track and locate staff at all times. So if you're a home health, hospice, or PACE provider, as well as, let's see, any of the centers, your renal dialysis, of course, you are going to be required then, and your community mental health, to be able to track staff. And if you cannot notify staff, they're out in the field, we have an emergency. So here's a chemical spill. And we've had this happen many times, as you have in Florida. Staff are out traveling. They may be the first identifier. There's a severe chemical spill. They can't get to patients who they were to visit to do wound care or other maybe high-tech or care needs, or even work with chronically ill patients. They notify the office, and then the office has to deploy to notify all patients who are in that region. They may want to shelter in. You want to direct them to close their windows and doors and not go outside. to monitor their local radio and TV stations, and that will be notifying them when we can get staff through. You may be keeping staff in the home there. If you have an aide there or a clinician that went, she may not be able to leave because of the region of the chemical spill, for an example. So how do you track and follow patients and staff who are out in the field? And of course, the policy is as well that if you can't notify them, you are required to notify the Office of Emergency Management. And that's in the final rule, as some of you know, and that includes for home health and hospice and PACE as well. So these are specific management requirements that will need to be addressed in policy and procedure. Your alternate site activation, should you have structural damage or you can't provide care and services, and then your short-term and long-term processes as well. How do we address in policy our patient population? So if you're caring for a population that has limited mobility, and you're required to provide transportation, do you have contracts for transportation? Now, many of you did very well. We have PACE providers who have experienced emergencies and they've had to evacuate their facilities and send participants. They either own trucks, but they have contracts with other providers for transportation buses to move patients or participants to other centers or return them home. So your policies will detail that, and you'll have contracts for that as well. Your management requirements in your EOP, of course, you're always going to have your line of authority. That will be in writing, and succession planning. And this has occurred, unfortunately, for people who have been in emergencies and staff could not be located, leadership staff could not be located. And then who's going to be succeeding them in their roles and responsibilities. So your response plans, your policies and procedures are specific to each event. And of course, then your succession planning, your short and long term will be detailed and planned, and then you'll test and drill and train on them. So we want to get very specific. Now, just a reminder that this session is being recorded, of course, and this will be available for you or other folks to access. The Region 3 Coalition will be sending out that access link, so you'll have access to all the webinars and materials. So what are some of the very common special occurrence protocols? Well, you do well with weather and natural disasters, but some of these unexpected are where we have to look at. And I tell you, we've had many problems, and I know that some of you have, when we've had a high discharge rate. We've had an emergency in certain metropolitan regions, such as Boston or Las Vegas, where we've had to evacuate hospitals to make room for potential injured, traumatic patients to have room in the hospitals for them. And so we've had to admit patients in some of our outpatient providers, home care and hospice and PACE, to make room in our facilities. So you want to have very special policies and procedures to accommodate each of these special events. What are the specific actions for leadership and staff? What are the specific communication procedures? And then who do you collaborate with and how do you collaborate with them? Contingencies planning is very important, and I think you have a great deal of experience with that in Florida. I know that our providers in Texas and in California, now Hawaii do as well, where maybe southern Florida was short on staff or needed assistance, and a call goes out to the state as well as other states to provide additional staffing because we're short-staffed. So many times during an emergency, we find, such as Katrina and 9/11, as well as during some of our hurricanes, that our staff have to care for their family and their extended family and neighbors, and they're not available to provide care and services to our patients and family and community. So your policies and procedures will be specific for roles and responsibilities for leadership and staff, what and when to do. I'll give you an example on the malware that's listed on this slide. Some of you have had some cyber attacks. Hopefully you haven't had the WannaCry. We have a new Trojan virus that is actually going viral right now. And your staff should be well aware if they have any situation where some lettering comes up quickly or some unexpected event on their electronic device, the first thing they should do is shut it down immediately and then notify the IT, their select IT staff, because that, of course, is the safest thing for them to do. And sometimes they need direction on how to shut it down when the thing continues to run and all of a sudden they see all these different notices coming across or those red triangles. What's a real common policy and procedure, of course, you all practice your fire safety evacuations for internal evacuations, and you do a great job with that. Many of us use the code red and race procedure. You may have this happen if there's an explosion, and so that practicing and documenting that is a good policy to review, and you all do a very good job with that. Sometimes it's our contractors, our replacement staff, or new staff that aren't updated with that procedure. So specific in your policy and procedure then would be, how do you evacuate safely? Where is your reassembly point? Do you have your emergency exit plan clearly posted? And are they identified at the doors? And I know many of you use your local fire and experts to help you do that on a regular basis. But where do you reassemble? Is the parking lot in the back? Is it the clinic or the center across the street? Where are the fire alarms located? Who notifies the switchboard and calls 911? And of course, some of you are trained in the use of fire extinguishers. Where are they located and how do you use them for what types of fires? Now, some of you need policies and procedures because you're developing a fire exit plan in your patient's home. So those of you that are home health, hospice, and PACE providers, you're required under the final rule now that you'll actually do on admission, you'll do a fire exit plan, an emergency plan with your patient and caregiver or representative. And we know home health has the new conditions of participation this year that detail and parallel this final rule. So we have hospice patients who are located on a second floor, and if there's a fire and they can't exit via the stairs, or maybe they're chair-bound or bed-bound, how do we safely evacuate them from the second floor of their home? Do they have operating fire alarms? And are the batteries up to date? And where are they located in the home or the facilities that they live? Some of them live in assisted living facilities, and those are better updated than many of the home situations we're in. So that's a common policy and procedure and practice that many of us do. Now, another policy that you might want to look at is chemical incidents or chemical spills or exposure, both internal and external. What is the leadership and staff roles and responsibilities? How do you maintain communication and who notifies the local authorities? And then how do you contact patients or staff if you need to contact them in a certain region? So that would be specifically detailed in your policy and procedure. Now, I see that the state has many of these policies, generic policies, located on the website. So you'll be able to go on those websites, look at their policies, just to look at yours to see if it's up to date and fits for your current location. Some of you only have one site, and some of you are part of healthcare systems and you're multi-site across the state or across certain regions. Another area, of course, you'd want a policy and procedure on bomb threat. And there are some very good policies with that. I do recommend that you also have a card at your office, in the receptionist, at your entrance to your center, and your office, so that people that are publicly answering the phone, if they have a threat, they actually have an instruction, a guide that they keep right near their phone. And we've seen this occurring more often now across the country. Some of it's related to religious affiliated organizations or other healthcare systems and some other events that have occurred. But it would be important for people to have that information. And some of you have exercised or drilled on that. I think that's a fantastic idea. The local authorities do a fabulous job on drilling on that. How do you notify your leadership in the center or in your offices or a facility? Of course, there's a bomb threat checklist that you can use and train staff and your office staff to follow. And then, of course, you want to turn off all radio, cell phones, and beepers, close the doors, and leave. You want to get out as quickly as possible. So how do you notify people over the speaker phone or over your communication system, that this is an evacuation? Some people use a code system, to notify security and to notify staff. And if you have patients in your center or facility, how do you safely and calmly evacuate everybody? And where are you meeting up? What's the reassembly place? So that's going to be helpful. If you haven't looked at that and considered that for an exercise or a drill, that's a possibility you might want to look at this year. Of course, we all need infection control policies and procedures, and a biologic event as well as a pandemic would be one of our policies. And of course, that close communication on your Florida health stat and communicating with your local and regional emergency management folks are critical. Now, if you're a home health and hospice provider, the new standards for the conditions of participation require that you have an infection control program and you're surveilling, monitoring infections with employees as well as your patient population. And you're actually looking for any clusters or symptoms that are unusual or unexplained that you would report to your local Department of Health folks. Now, if you have staff that are traveling, that's another reason that you want to monitor some of their symptoms or infections. And certainly, of course, have enough personal protective equipment for them to care for our patients and patient population. A supply policy is helpful. Now, everyone needs a policy on emergency disaster or emergency preparedness kit. It's recommended that you have one in the office, and those of you that have field staff, they would have a kit in the trunk of their car if they traveled to see patients or in families with their car, an emergency kit. So you'd have a policy for emergency disaster kit. And what supplies would be included? Of course, we always need the masks and the gloves and the gown. And of course, that would be expanded with dressings that would be commonly used for your population, sometimes batteries or other protectors, hair covers and feet covers and other dressings and Foley catheters that you might need for your specialty population. Of course, you'll have a a policy for loss of facilities services. Now, some of you are required to have that. So, for example, PACE, you're required, just like our community mental health centers are. What happens if the internet goes down, if you lose power? Do you have a backup memorandum of understanding for a generator? Or have you purchased, some of you have already purchased industrial generators, but they are expensive, and we have had, as you know, in several regions, mortalities because of not having those backup emergency power when needed. So in the final rule, they did a good job for inpatient and some outpatient providers who have to have required emergency power if your power goes down. So consider that carefully for the facilities that are required to have that. It's the same with those of you required to shelter in. Like hospice, if you have hospice house, or your PACE, your renal dialysis facilities, your community mental health facilities, if you're required to have a shelter-in policy, then you're required to have sustenance policies. How much food and water do you have to have on hand for staff, for patients, for volunteers, for people that may be there when something happens and you're required to shelter in? There was an explosion or a terrorist event and you're required to shelter in for a certain amount of time and you've lost power. So, of course, facility plans, rental agreements, you want to consider that very carefully. And I know that you do that with the life and safety experts who are located in your regions. Many of you have worked very hard on those items, and that's a challenge for all of us, and it's an expensive item. So other policies and procedures, the one that I really want to point out is the emergency clinical documentation. So you'll need a policy that if during and after an event you've lost power, you don't have an electronic record, or you don't have power to actually bring up your electronic record, where is your emergency documentation? So the facilities, all of us need to have a policy on that. And then home health, hospice, and PACE would want to keep that emergency backup in their backup office with their office emergency kit. And of course, by then, usually we have an 1135 waiver that streamlines our clinical documentation. So you'll have a streamlined assessment and visit plan to provide care during an emergency, maybe in an evacuation center. So your policies and procedures are specific to you as a provider and your patient population. And I think the really a challenging one for some of us is that tracking system for staff and patients. For those of us that are required to track staff and patients during and after an emergency, trying to keep track, and you've all done this. You've called them ahead of the hurricanes. You've identified the evacuation. You've pre-registered them so you know where they'll be going. As far as I know, we didn't have trouble in Florida. We had trouble in Texas where we pre-registered our patients for evacuation centers, and one facility would not take the pre-registered ones and during Hurricane Harvey. So that was a challenge that they're trying to address now so that doesn't occur again. But how do we keep track of staff that are working in our patient population so we can report to emergency management if we can't locate them, and that we make sure we get them in a safe place and they all know the plan prior to that emergency if it is a predictable emergency. So these are your quick policy and procedure checklist, of course. What applies to you? I would urge you to look at the active shooter and civil disturbance if you don't have that in your HVA. I included a sample policy, a sample active shooter policy for you in the tools in this webinar. And it's only, I want to say, a 3-page policy that you actually could pull and see Does it include some of the elements that yours does, and is this something that you should include in yours? In that active shooter, I've been impressed with those of you that have actually performed that exercise, done an exercise with local partners. That's been a really learning experience for many of us. But having that prearranged code for communication, for that violence in the workplace as well as that active shooter is very helpful. So take a look at your policy and see if you need to update it, or you might even need to add one to your policy and procedure. And of course, if you don't have a bomb threat one, then I would urge you to look at that as well. Now, the patient education policy and procedure, that is specifically required for home health, hospice, and PACE. So you would need a separate policy and procedure on admission, what's in the assessment, and what's required in your patient-specific. It has to be a patient-specific emergency plan, and most of your EMRs actually have that. So that works out well. Your emergency documentation policy then will follow your electronic record, some of the software that you're using. You will just streamline that process. Some of us haven't used paper in years, but you'll have templates for that, and you'll be informed by your leadership when and how to access and use that emergency documentation. Other specific policies and procedures would include evacuation. Now, for home health, PACE, and hospice, we're required in our policy to address if we have patients who are in mandatory evacuation zones who refuse to leave. And of course, calling and negotiating with them and finding out why they won't leave, and of course, letting them know we won't be able to service them. Then we're required, because the final rules, and every state is different, but in the final rule, they want you'll have to report it to EOM that they refuse or delay evacuation, and what can we do to work with them? Most of the time it's pet related that they don't want to leave. So having a plan ahead of time for pets, an emergency plan, is very helpful. Florida did great with that last year. Sheltering in policies specific to outpatient providers with emergency and standby power, and then emergency plans for your patient population. So I listed those policies specifically so you would know what you would need to do. Now, those of you that have to have detailed evacuation plans, you want to be clear about alternate sites and memorandum of understanding for providing services at alternate sites, or having partnerships where staffing, that you could receive staff and staff support during that. And then how will you communicate those changes with your patients? PACE, of course, in our PACE facilities, we need to have an internal holding area where we're staging and prioritizing patients and then transporting them to an alternate site and communicating with staff and their family members if we had to evacuate them because of an emergency. So I listed for you some additional specific outpatient plans that you would want: safe evacuation and subsistent needs, as well as alternate locations. You'll want to look at your policies, procedures, and contracts to make sure they're updated for these specifics. Now, where are we? So for the shelter-in policies, and oftentimes that occurs with something, it's an urgent explosion. I've been involved with agencies that have had an explosion and they've had to shelter in, gas, they've had down the street chemical spills, flooding, and of course securing the building and securing and making sure staff and patients and volunteers who are in the facility are safe. And then of course having the sufficient resources for them to care for those who are in the facility, as the hosting procedures are critical. Now that's a minority of you, but I just wanted you to be able to see that some of your outpatient partners have to do a shelter in. If you're a hospice and you have a hospice house, of course, you would be required to have shelter and policies, and that would include for volunteers and staff that you would have facilities and food and a plan for food and water, waste disposal, medications if needed. Now, what do? Our building's been damaged. We can't return. What's the reconstitution process? And that would be detailed in your EOP and your policies. You'll have an alternate site, but how will you transition back to? And many of you have a lot of experience with this, going from emergency back to normal operations and continue to provide care. Some of you have had severe structural damage and you've had to relocate to another site and to make full business ready and ready to go. So your considerations here, of course, are time frame damage assessments, and who do you need to notify in terms of we're going to do business, these are our alternate sites, and or we're transferring our patients to other facilities, and they'll be providing care. In the rare case, of course, that you're unable to execute essential functions during or after an event, then, of course, you'll be transferring authority and responsibility. You would be notifying your local, state, and federal government, and then, of course, you'd be working with them on patient and staff notification, on how to transition patients and staff, and work with your community coalition partners. I know that's a rarity, but on occasion that does happen post. Now, what are some survey considerations as we're finishing up here? If surveyors come on site, they want to see that you've done your annual HVA and you actually have policies and procedures that address those high-risk areas. Have you considered high risk not only in your provider type, but in your region and with healthcare providers across the country? They'll ask for your evacuation plans, internal and external. Right in the final rule, they'll ask for your emergency preparedness kit and policy. And specifically, if you go down to that fifth bullet, you'll see right in the final rule for survey considerations, how does the facility address an interruption in communication, including cyber attacks? That's why we would recommend that malware would be one of your policies and procedures. And does your EOP designate authority and succession planning? And many of you have worked really hard on that. So I've listed some resources on this last slide for you. I would urge you to take a look at their policies and procedures if you haven't had time. That may help you to brush up or tighten up on yours. What gaps have you identified? Do you need to update any of your policies and procedures? Civil disturbance is another one that I find people often don't have, and you might want to consider that depending on your location. Another tool that I included in your packet is that facility evacuation checklist. It's just a quick checklist that you might want to look at. It makes it easy for staff if you have checklists that go with certain policies and procedures that you can really educate or update them on, and they can use as quick reference guides if needed. They know exactly where they're located, and they're a quick reference guide for them. What are their roles and responsibilities? So I think we've answered all the questions. If you have others, you can email me at rbc@netstep.net. And what I'll do in the beginning of webinar 3 is be sure to review any of the Q&As that I get so we can go over them specifically regarding policies and procedures and where you're uncertain and what other providers ask, because we can certainly learn from one another. I appreciate you all participating today. Hope you have a wonderful week, and Memorial Day is coming up. Thanks again for participating.